Hello everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series, which is pathology lectures and guidance for PG students and consultants. We have a YouTube channel where you can access all the videos. We also have a Telegram group which you can join this group. This is very helpful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available, and we have a master integration key by which you can navigate between the PDF and the YouTube. We invite people to come and join us and give lectures on this platform. It will help all students and consultants worldwide. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 1Y, which is Uropathology. The topic of the day is Prognosticating Prostatic Carcinomas, Modified Gleason Scoring Grading System. To talk on that, we have Dr. Mitadru De Sarkar, who's an MBBS from JIPMER, MD from JIPMER, a consultant histopathologist at the Kolkata Reference Lab, PathLab, a consultant histopathologist and cytopathologist at Calcutta Heart Clinic and Hospital, a consultant histopathologist at the Wizderm PathLabs, which is a specialty pathology, Dermatopathology lab. He's an ex-assistant professor in the Department of Pathology of SMV Medical College and as an ex-consultant pathologist of SRL Diagnostics, Fortis Hospital, Anandapur. Dr. Sarkar has authored a book which is Brain Tumor Pathology for Postgraduates, which is available on Amazon. There's also a Kindle version of that. It's a very good book, and you can buy that, or you can even have the Kindle version of it. It is recommended for all students, postgraduates, as well as consultants. With this, I would request Dr. Mitadru De Sarkar to start his talk. Over to you, sir. Thank you so much.
Hello, and welcome to this discussion on the role of prognostication in prostatic carcinomas, with special emphasis on the modified Gleason scoring or the grading system. So in this particular discussion, we shall talk about the original Gleason grading system and its various modifications. So the chapter scheme will actually follow this particular order. We shall be talking first about the various patterns and the grades within the scoring system, after which we shall briefly discuss about the original Gleason system, and then the various consensus modifications which were carried out in the ISUP 2005 and 2014 meetings, consensus meetings. Finally, moving on to the ISUP 2019 guidelines, and we shall talk about these 3 modification schemes regarding their application in both prostatic biopsies as well as in the radical prostatectomy specimens. And at the end, we shall discuss in brief about the various recommendational differences between the ISUP 2019 guidelines and a set of guidelines brought out by another organization, that is the J&T Urinary Pathology Society, or the GUPS, which came out in the same year. So we shall be talking about the ISUP 2019 guidelines versus the GUP 2019 guidelines in the last few slides. So the original Gleason system that came out in the year 1966 was a beautiful prognostication system that aimed to segregate the various cases of prostatic carcinoma based on a combination of histology as well as the clinical stage. So the histology was based on basically what we talk about in the form of the primary pattern and the secondary pattern. Later on, subsequent modification of this system dropped the clinical stage out of the calculation scheme. So we were left with a set of histological scores of 2 to 10. Following the various consensus meetings which were set up by International Society of Urological Pathology in the year 2005 and subsequently 2014, there were various modifications which were made to this scheme of things. The 2005 ISUP consensus meeting was a milestone of sorts because it changed quite a lot of things as far as the rules of Gleason scoring reporting were concerned. Comparatively, the changes which are proposed in the 2014 meeting were very minor, but the most important thing that came out of the 2014 meeting was the concept of the Gleason grade groups. These changes, we shall talk about in the form of the ISUP 2005/2014 modifications, were subsequently adopted by the WHO and found their way in the WHO 2016 scheme of things. And subsequently, as I've already said, two separate consensus meetings were brought out by ISUP and the Genitourinary Pathology Society. These were slightly conflicting, especially when it came to radical prostatectomies, and we shall see that particular issue in the last few slides. Now, what is the significance of Gleason grading? Of course, we know that it predicts various kinds of outcome measures in the case of the CA prostate patients, especially for the patients who are on various kinds of treatment or on the principle of active surveillance. It helps to predict the rate of biochemical failure of PSA levels, as well as the stage, the degree of metastasis, and death. This is an independent predictor of biochemical failure after the patient has been put on neoadjuvant or adjuvant hormonal treatment. The patients with Gleason score of 6, that is 3+3, are often candidates for active surveillance. That is, you just monitor these patients for increase in PSA and carry out periodic biopsies over a period of 3 years once. And however, if there is even a small amount of pattern 4 coming into the picture, which gives rise to the Gleason score of 7, this is a critical threshold point, because at this point you will need to give some kind of a definitive treatment, for example, radical prostatectomy, often with lymph node sampling. And as per the CNCN guidelines, depending upon whether the patient belongs to the grade group 4 or 3, you will actually choose the period of neoadjuvant and androgen deprivation therapy. That is, if the patient is in the grade group 3, you would choose a 4-month period of treatment, while the patients in the grade group 4 would get 18 to 36 months of androgen deprivation treatment. Gleason score of 8 to 10 usually requires a combination of multimodality treatment, including adjuvant therapy or radiation. So a very oversimplified prognostic model actually helps to categorize these cases into a set of clinical behaviors. Like, for example, if you have a well-differentiated Gleason score, 2 to 4 scores of 2 to 5 are usually are of historical interest. We shall talk about the score 6. So most of the patients in score 6 will be incidentally discovered, and they have a good prognosis and can be candidates for active surveillance. However, once you get into the score 7, that is a moderately to poorly differentiated tumor, the stage is of course higher, but these are still potentially curable on radical prostatectomy. However, once you get into a higher grade tumor of scores 8 to 10, you have advanced stage disease, and cure is usually unlikely. We shall have to talk a little bit about the Gleason's original grading system, because this is where the things all come from. So once you have an idea about the original scoring system, it will help to understand the various modifications that came out in 2005 and 2014. So the first two patterns, first, something that needs to be gotten out of the way, we shall be talking about patterns and grades. So while the grade is a numerical number, what we look at is actually the patterns. That is, we look at the architecture of the glands in the slide, and this helps to predict which particular grade this particular area belongs to. Like, for example, these patterns 1 and 2, which is actually of historical interest, shows a circumscribed focus, with the pattern 2 showing a few of the query suspicious glands moving out of the area of circumscription. Now, these are of historical interest and do not figure in the recent scheme of classification. But starting from the pattern 3, going on to pattern 5, 3, 4, and 5, you see an increasing order of complexity of the glands. So the minimum set of features for a gland to qualify as a pattern 3 would be an infiltrative pattern of atypical glands with a very well-formed glandular lumen. But once this gland starts to coalesce, you have varying degrees of cribriforming because of the joining of these glands, and over an increasing spread of grades, you see that this degree of cribriforming is increasing, and towards the end, that is in the pattern 5, you have the tumor mostly in the form of solid sheets or in the form of trabeculae, etc. So as I've already said, the way by which you point out a certain grade of the prostatic carcinoma is to look at the histological pattern. So if you have a pattern of well-formed glands, which could be tightly packed or which could be loosely arranged, you have a grade 3 area. If the glands show varying degrees of fusion and cribriforming, or if they're very ill-defined, they would belong to the grade 4. A predominantly solid pattern or a single cell pattern of infiltration would belong to the grade 5 architecture, that is the grade 5 pattern. So let's have a quick look at the various types of patterns that you see in the case of prostatic acinar carcinomas. So in the case of Gleason pattern 3, which is the bare minimum pattern score that you can give, these atypical glands are seen to infiltrate between the normal prostatic acini. But the glands are all discrete, and you can make out individual glands with their lumina. So this is the architectural pattern that you see in the case of pattern 3. Like, say, for example, in this case, in a prostatic biopsy, you see this small atypical infiltrating glands with a properly well-defined lumina infiltrating through the fibromuscular stroma. So this is a pattern 3, which would correspond to a grade 3 tumor area. Similarly, in this case, you have very well differentiated tubular glands which are infiltrating, but these are atypical, obviously, because they lack a myoepithelial layer. They lack a basal cell layer, and they are seen to infiltrate within the stroma. Again, in this particular case, you have varying calibered atypical acini infiltrating through the stroma, but most of these acini have got a proper well-formed glandular lumen. So this is again a pattern 3 in a grade 3 area. Sometimes these glands can seem to coalesce together, giving rise to a query cribriform pattern. But if you see them at a higher power, you'll see that there is a proper lumen to these glands, and you have some healthy amount of stroma between these glands. So this is not a cribriform pattern 4 pattern. Rather, this is a pattern of back-to-back coalescent but non-cribriform glands, which still belongs to the pattern 3. Now, this is a case where the glands look as if they are quite separate from each other. Okay, so this looks predominantly like a pattern 3, but then there are some of these glands which look like a bit of ill-formed acini without a proper lumen to them. So there's a suspicion about this particular area going into the grade 4 architecture. So these are the various types of architectural patterns that you can see in the case of pattern 3 corresponding to Gleason grade 3 areas. Now, moving on to the next pattern, that is the next higher pattern. Here you have what looks like a solid mass of cells punctuated by multiple glandular spaces, but between the glandular spaces, you do not see stroma, rather you see a mass of cells sitting between the adjacent punched out cribriform spaces. So this is the characteristic cribriform acinar fusion that you see in the case of Gleason pattern 4 corresponding to grade 4 areas. And why is it important to make a note of this particular cribriform architecture? Because this particular architecture has been shown to be an independent predictor of poorer outcome in the case of Gleason score 7, that is 4+3 or 3+4 tumors. So if you see cribriform pattern, you are supposed to make a note of the presence of the cribriform pattern in your report, and also talk about the percentage of the area which is occupied by the cribriform pattern. However, in real life, sometimes this cribriforming will not be as obvious and as striking as the case that we saw before. So sometimes you can have these atypical glands coalescing together without that characteristic classic punched out appearance. But over here, you see that the glands are all fused together without any stroma between these atypical glands. So this also qualifies as a cribriform pattern. The other types of glands which are seen in the case of the cribriform, in the case of the pattern 4, Gleason, are the poorly formed glands. As I've already said, in the case of pattern 3, you get glands with proper well-formed lumina, while in the case of the pattern 4, you get areas which look like they are small glands forming, but you don't have a proper lumen to them. Okay, so these would actually qualify as poorly formed glands, and such poorly formed glands would also go into the pattern 4 corresponding to grade 4 areas. Okay, so for example, although you have well-formed pattern 3 like glands here, you also have smaller glands which look like incipient acini, but they don't have a proper lumen to them. So these are grade 4 areas. Again, you have a mixture of grade 3 as well as grade 4 types of ill-formed glands in this particular slide. Now, this concept of the poorly formed Gleason pattern is important because there is a chance of two pathologists differing as far as the approach to the understanding of the pattern 4 atypical glands, atypical ill-formed glands is concerned. So the consensus is that if you do not have more than 10 such glands, and if these glands are adjacent to glands which are very well formed, the tendency is to go one pattern lesser. So in case of an uncertainty, if you have a query between a pattern 3 or a pattern 4, try to see whether this particular consensus criteria is reached, and if not, then default to pattern 3, because if it were to go out to institute which specializes in neurologic pathology, most likely they would rate this particular poorly formed glands as a pattern 3 area. There is another another kind of pattern which also qualifies as a pattern 4. Now these are areas where the acini take up a clear cell-like architecture, almost like a clear cell RCC. So this hypernephromatoid pattern also qualifies as a pattern 4. So this is a particular case where you had mostly pattern 4 areas, but at the same time there were these areas with a very clear cell-like appearance to them. So this is also another pattern which is associated with pattern 4. And lastly, there is this concept of glomerular glands seen in the case of pattern 4. For example, these are multiple areas where you have pattern 4-like areas. And if you see this coalescent atypical glands with cribriform spaces, at some places, this atypical cell seems to be forming glomerular structures within the lumen. And these kind of atypical glands also qualify as a pattern 4. So there are various types of architectures, all of which point towards the Gleason pattern 4. This could be cribriform glands, this could be fused glands, poorly formed glands, or a hypernephromatoid pattern. Now, the concept of this cribriforming is important because as far as the evolution of the original Gleason into that of the modified ISUP 2005 and ISUP 2004 is concerned, we see that there is a steady rate of conversion of what were originally cribriform pattern 3 in the original Gleason getting shifted to the pattern 4, basically, to the point that although ISUP 2005 allowed some degree of minor cribriforming to be still allowed within the pattern 3, as far as ISUP 2014 is concerned, any degree of cribriforming now qualifies as a pattern 4 and not a pattern 3. So in the current scheme of the WHO, in the current scheme of the ISUP 2014 classification of Gleason's, any degree of cribriforming would now count as a pattern 4, and only discrete glands will stay in a pattern 3. So this is the original Gleason's scoring system, where you see that a few of the cribriform glands with smooth and rounded outlines would still figure in the pattern 3C. We don't have any of these patterns now. All of these cribriform architectures would now qualify as a pattern 4. So this was the jump. This was the original Gleason grading system, and this was the ISUP 2005 modified system, where you see that a proportion of these cribriform glands are remaining in pattern 3, especially those glands which are very small, rounded, and with a well circumscribed edge. But most of the cribriform pattern has actually gone into the pattern 4. While in the later modification of the ISUP 2014, each and every of the cribriform patterns is now counted within a pattern 4. And this is the approach to the current grading scheme of things. So as per the ISUP 2014 modified Gleason grading, which is the one which you will follow in your routine practice, you have basically 5 patterns, but remember these patterns 1 and 2 are of historical interest, and you will not make diagnosis of pattern 1 and 2 in a needle biopsy, because most of these cases will actually turn out to be wrongly diagnosed cases of adenosis. So as far as our routine practice is concerned, in the case of needle biopsy specimens, you will start from the pattern 3, and depending upon the various types of histological architecture, you will move on to pattern 4 and pattern 5. So now, a few words about this, about the importance of scoring the pattern 4 in your needle biopsies, because the presence of pattern 4 is a very important guiding principle as far as the cases of prostatic acinar carcinoma is concerned, because patients who have got more than 5% of pattern 4 will need basically some kind of a treatment, some kind of a definitive treatment in the form of a prostatectomy at least. While those individuals who have got less than 5% pattern 4 architecture in their overall Gleason score can still be candidates for active surveillance, especially if they do not have the cribriform kind of a pattern that we have seen initially. And depending upon the degree of the extent of the pattern 4, you can basically score your tumor as 3 plus 4 equal to 7 or 4 plus 3 equal to 7. And now that's important because quantification of the percentage of pattern 4 will actually help the clinician to choose whether adjuvant radiation therapy is to be given in this particular case. And increasing percentage of pattern 4 on your needle biopsy correlates with an increased risk of biochemical risk of recurrence after a radical prostatectomy. So it's very important that after giving your total Gleason score, if the score is 3 plus 4 equal to 7 or 4 plus 3 equal to 7, you have to give a percentage distribution of the presence of the pattern 4. That is how much area of the tumor is actually occupied by the pattern 4 areas. Now moving on to the next higher architecture, that is the higher pattern, that is pattern 5. You see over here that there is a sheet-like area with these cribriform spaces, which would look like what you see in the case of a pattern 4, but then you are also having these dirty amorphous granular areas, which basically count as necrosis. And whenever you see necrosis in the setting of a pattern 4, you will immediately upgrade that particular pattern to a pattern 5, corresponding to Gleason grade 5 areas. Sometimes these atypical glands can look again like the kind of fused cribriform glands that you see in the case of pattern 4. But if you were to look into the lumina of these glands, instead of secretions, you would see this kind of amorphous cellular debris which are present in the lumen. Like say, for example, in this case, you have some of these fused glands which look like pattern 4. But if you look closely into the lumina, you can make out the ghost outlines of the cell which are sitting in the lumina. So automatically the presence of necrosis makes these glands a pattern 5. Apart from this presence of this comedo type of necrosis, you also have various other patterns which fall into a pattern 5. So for example, you could have a solid sheet-like mass of cells without any cribriforming or any glandular differentiation, or you could have these cells going through the stroma in the form of individual cells, sometimes forming narrow trabeculae. That also qualifies as a pattern 5 because there is absolutely no glandular differentiation in these cases. And sometimes they can have a signet ring cell-like appearance, which also qualifies as a pattern 5. So for example, in this particular case, you just have a solid sheet-like area without any kind of glandular differentiation, qualifying as a pattern 5. In these two cases, for example, again, you have a sheet-like architecture and linear extension in the form of slender trabeculae, but no acinar differentiation whatsoever. Here you can see the normal prostatic acini, which are present in proximity to the infiltrating tumor cells. Again, in this particular case, you have areas where the cells are discretely infiltrating into the stroma individually, but not forming any glands. And again, over here, you have a sheet-like architecture. Also observe that as the pattern goes up into the grade 5-like pattern, you have the cells assuming a kind of a neuroendocrine small cell morphology. So this is a higher power view of some of these cases where you see that the cells, again, at some places, they look like they're having a neuroendocrine kind of an appearance with stippled chromatin and sometimes molded angulated nuclei. So this is a true cut biopsy. These are two cases of true cut biopsies, basically, where again, you have a sheet-like architecture of these atypical infiltrating cells, qualifying this area as a pattern 5, that is a grade 5 architecture. Again, in this particular case, you can see the pattern 5 areas with the cells showing a focus of nice perineural invasion. And sometimes, as I've already said, these sheet-like infiltrating cells can look like histiocytes or even like atypical signet ring cells. So these are the various kinds of a pattern that is associated with the Gleason pattern 5 corresponding to grade 5 areas. And at the end of the day, you will have to remember the various kinds of architecture which are associated with the various kinds of patterns, because based upon that, you will have to basically talk about your predominant pattern and your secondary pattern or your highest grade patterns. And you will have to add up those patterns to get your score. So it's important that you know each and every of these architectural patterns by heart. Now, talking about the scoring system, we have already seen about the patterns and the various grades which correspond to these patterns. Now, once you see a slide, you will have to mentally segregate the areas which are showing you the most common, that is the dominant pattern, and the areas with a secondary, that is the worst remaining pattern. So for example, if you are to take these two images as a single core, you see that majority of the area is occupied by pattern 4 areas. So that would count as your dominant grade, while the secondary area with a smaller area of representation of pattern 3 would count as the secondary or the second worst remaining pattern. You add up these two patterns of the primary pattern and the secondary pattern and get your total Gleason score. But this is the original Gleason system. Keep that in mind. The later modifications of this Gleason system have actually deviated from this norm, but you will have to remember about this particular system because that was the baseline on which those ISUP guidelines were later modified. So here we are talking about a case with only a pattern 3 and a pattern 4, that is with only two patterns. But what happens when you have a case where you have three patterns? As we already know, the patterns can be 3, 4, and 5. So in a needle biopsy where you have a pattern 3, 4, and 5, as per the original Gleason system, if less than 5% of the area was occupied by the pattern 5, you would omit the pattern 5 in your final score. That is, you would give the report as a 3 plus 4 equal to 7 and make a note of the pattern 5 being present in less than 5% of the area and account for it as a tertiary grade. Now, this is a major approach which basically completely changed with the ISUP 2005 guidelines. So as per the ISUP 2005 guidelines, if you have a tumor, say with 60% of Gleason grade 3, 36% of grade 4, and less than 5% of grade 5, that is the highest grade possible, less than 5%, as per the original classic Gleason score, you would basically score it as a grade 3 plus grade 4 with a mention of the grade 5 area being present as a tertiary pattern. But as per the ISUP 2005 guidelines, the way in which you report such cases is the most plus the worst. That is, the grade 3 being the most common pattern will come first. Then you add it to the worst grade pattern, which in this particular case is a grade 5, that is the one with the 4% pattern. So you totally ignore the 36% of the secondary grade. So the most common pattern plus the worst grade pattern now will count as the total Gleason score as per the ISUP 2005 modifications. So as per the ISUP 2005 guidelines, there is no threshold for the amount of the highest pattern of the cancer, while the classic system required at least 5% of the area of the slide to figure the grade 5 element. So the other few changes which were made by the ISUP 2005 modification is that the cribriform pattern was mostly shifted over to the grade 4 architecture. However, even at this stage, very rarely small round circumscribed cribriform pattern was allowed. And grades 1 and 2 were now considered to be of historical significance, and they were told to be rarely used, if ever. So these are the various ISUP 2005 modifications which you will have to remember. And this is a table which shows you the difference between the original Gleason system and the 2005 ISUP modified Gleason system. So what is the major impact of this 2005 modification of the Gleason grading system? Of course, many of the cases which were being scored as 3 plus 3 equal to 6 were now being scored as 3 plus 4 equal to 7, because many of the so-called cribriform, minor cribriform pattern was actually getting shifted onto the pattern 4. So there was an overall incidence of increase of the degree of the scoring in the needle biopsy specimens, and that was tallying better with the radical prostatectomy scores, which were seen finally. However, because of the sudden shift of this cribriform architecture from this pattern 3 to pattern 4, there was increasing amounts of disagreement between the pathologists as far as the pattern 4 was concerned. And it was seen that majority of the general pathologists who don't report such cases routinely were basically overcalling Gleason pattern 4 when it was actually a circumscribed pattern of Gleason 3 areas. And in this particular consensus classification, it was agreed that a tertiary pattern should be better defined. Now let's put this particular approach to use and see how the ISUP 2005 modified Gleason grading system applies in the case of needle biopsies. So if you have a case with a dominant pattern of pattern 4 and with a secondary pattern of pattern 3, of course, your total score would be as per the original Gleason grading system of 4 plus 3 equal to 7. However, in such case, if you had a minor, that is less than 5% of the area was occupied by the highest grade pattern of pattern 5, you would now oblige the highest, the most common pattern, that is the dominant pattern, plus the highest grade pattern, and you would score such cases as a Gleason score 9, that is 4 plus 5. Now, what about cases where you had two patterns, one dominant pattern and one secondary pattern, absolutely no higher grade pattern, but this secondary pattern was occupying less than 5% of the area? In such case, you are free to ignore the lower grade pattern and score this particular tumor as a doubling up of the dominant pattern. So in such cases, you would score this particular case as a pattern 4, that is 4 plus 4, and give it a Gleason score of 8, and totally ignore the secondary pattern if it is occupying less than 5% of the area. So in this particular case, we can see how this 2005 modification can be put to use. So like in the first case, you have as a predominant pattern, you have pattern 4, and as a secondary pattern, you have pattern 3, but occupying less than 5% of area. So totally ignore the pattern 3 and give it a Gleason score of 4 plus 4 equal to 8. In the second case, you have a predominant pattern of pattern 3 and a secondary pattern of pattern 4, which is obviously higher than pattern 3. And even if it occupies less than 5% of the area, you will have to take it into consideration because you are going by the pattern of the most plus the worst. So you will have to give it a Gleason score of 3 plus 4 equal to 7. And in the last case, where you have a combination of 3 patterns present in the same core, that is pattern 3, pattern 4, which is the secondary pattern, and the pattern 5, which is the least amount of the pattern in this particular case, occupying less than 5% of the area, which was priorly called tertiary pattern. You would now score this case as a combination of the most, that is 3, plus the worst, that is 5, and totally ignore the secondary pattern. Now, these are a few textbook images, which again gives you an understanding of how the scoring concept is. Like, for example, in this particular cases, you see that the glands are very well formed with a proper lumen to them, and they're seen discretely infiltrating through the stroma. So there is no pattern 4 whatsoever. So this would get a Gleason score of 3 plus 3 equal to 6. Again, the left image shows very well formed infiltrating glands. Again, it would get a Gleason score of 3 plus 3 equal to 6, while in the right-hand image, you have occasional glands with a proper lumen, but most of these areas look like they are incipient glands without any proper lumen whatsoever. So those would count as pattern 4. And given the fact that the overwhelming majority of the slide is composed of this kind of glands, you would give it a total Gleason score of 4 plus 4 equal to 8. In these two cases, you get mostly a sheet-like architecture of the cells without any kind of cribriforming even. And so this gets a Gleason score of 5 plus 5 equal to 10. Whereas in the second image, you have the cribriform architecture, but at the same time, you also have necrosis. Again, qualifying this particular case as a pattern 5 mostly. So here you would give it a score of 5 plus 5 equal to 10 of the comedocarcinoma pattern. Again, a few of the images for you to practice and put this particular principle to work. This is a case of Gleason grade 3 plus 3 equal to 6. Also another case of Gleason grade 3 plus grade 3 equal to score 6. In this particular case, while you have the well-formed atypical infiltrating glands of pattern 3, that is grade 3-like areas towards the lower right, as you go towards the upper left, you see that the glands are they're getting fused together, forming this kind of cribriform spaces. So that's the pattern 4 area. And over here, because the grade 3 areas are more in amount, that is, this is the predominant grade. So the final grade would be, the final score would be a grade 3 plus grade 4 equal to score 7. In this particular case, again, you have very well-formed glands of the pattern 3 towards the bottom half of the screen, while towards the upper end, you have this ill-formed, that is the poorly defined glands of pattern 4. So this gets a score of 3 plus 4 equal to 7. Now, from the ISUP 2005 modifications to the consensus meet in 2014, which came out with a new set of guidelines, most of what was already being followed as per the ISUP 2005 modifications were retained. But the most important change that came out of this particular consensus meet was the concept of the grade groups. So we shall have to talk about, briefly about these grade groups in the context of the ISUP 2014 modifications. So we see that as far as the total Gleason score is concerned, in our real life practice, we get scores from 6 to 10. Now, you cannot just sometimes go and tell the patient that you have got a total score of 6. So the patient will tend to get scared with such a high number. If you say that out of a total score allowable of 10, you have got a score of 6. So it would be better if you could compress this set of scores into a set of grade groups starting from 1 to 5. So instead of saying that you have got a score of 6, you can say that you belong to the grade group 1, and that would make the patient feel a bit more relieved. Now, this particular case over here, when we talk about the grade groupings, you have to remember that this is actually nothing new. This is just a compression of the set of scores which we have already talked about priorly. So the scores are kind of getting compressed into groups, and this grouping of the patients, it correlates well with biochemical as well as the risk of clinical recurrence, as well as the disease-specific survival and overall survival. Now, the other changes which were brought about by ISUP 2014 modified Gleason scoring system is that in the case of needle biopsy, you have reverted back to the original Gleason approach of a predominant histologic grade added to the highest non-predominant histologic grade, that is the secondary grade. However, tertiary pattern was not allowable. That is, if you had a combination of more than 2 patterns, say for example, in this case, you had 75% of pattern 3, 20 to 25% of pattern 4, and less than 5% of pattern 5, you would still score it as per the ISUP 2005 guidelines as a most, that is pattern 3, plus the worst, that is the pattern 5, that is a score of 8. The concept of tertiary pattern applied only in the case of radical prostatectomy specimens, where you would report out the score as a combination of the most common and the second most common patterns. Tertiary pattern in the case of prostatectomy would be if the tumor were present in less than 5% of the tumor nodule. And in such cases, you would report such scores as, say, Gleason score 3 plus 4 equal to 7 with a tertiary pattern 5 occupying less than 5% of the tumor nodule, or a 4 plus 3 equal to 7, that is a grade group 3, with less than 5% of pattern 5, that is a tertiary pattern. Now, these are the various grade groups which are defined by this particular consensus meet. Now, let's look at the concept of grade groups and the corresponding Gleason scores. So, as I've already said, you had 5 grade groups, 1, 2, 3, 4, 5. The first grade group is basically 3 plus 3, that is 6, which is the least you can get in a case of a prostatic cancer. While moving on to the higher grade groups, if you have even some amount of pattern 4 coming into the picture, you see that there is a jump from the grade group 1 to the grade group 2, which is why it's so important to talk about the extent of the presence of pattern 4 in your needle biopsy specimens. If pattern 4 becomes the dominant pattern instead of pattern 3, you have a further jump from grade group 2 to grade group 3. If you have a case where it's mostly pattern 4, or if you have a case with, say, pattern 3, but with the maximum allowable pattern, that is pattern 5, you will now have a jump from the grade group 3 to grade group 4. And of course, if you have a case where it's only pattern 4 and 5 in various combinations, you would have jumped to the highest grade group, that is the grade group 5. And this particular grade grouping approach was validated and also incorporated in the 2016 WHO classification, so that now it's mandatory to give the grade group of the patient when you are giving the total Gleason score. So, of course, it's very easy to define such grade groups, because all you have to think of is you have to think of the primary pattern and the secondary pattern and talk about the kind of architecture which is the most common and the type of architecture which is of the secondary degree in such cases. This particular illustration puts this thing to a practical application level nicely. So I have actually crossed out the first pattern because this pattern of 1 and 2 don't apply in the case of needle biopsy. These are wrong patterns to talk of when we talk of needle biopsy specimens. They don't exist. For us, the minimum pattern would be a pattern 3. So the first line over here shows the range of kind of patterns that you can see in the case of pattern 3, whereas the next 2 rows show the various kinds of architecture of pattern 4. The last row shows you the pattern 5 pattern. So if you have a dominant pattern of pattern 3 with a secondary proportion of pattern 4, you will get a total Gleason score of 3 plus 4 equal to 7, and 3 plus 4 equal to 7 puts the case in a grade group 2. Similarly, if we were to have more of this pattern 4 as a primary predominant pattern and a secondary pattern of pattern 3, you would give it a total Gleason score of 4 plus 3 equal to 7, and these would move into the grade group 3, and so on and so forth. So this rather elegant system of segregating your cases and presenting it to the patient, it kind of seems intuitive that you should always report it out along with the Gleason grade and the Gleason score. But as per this particular article, even in the year even in the year 2019, this concept of grade groups was not being routinely utilized as far as the reporting of prostatic biopsies was concerned. And this is something that is bound to happen if you do not follow the CAP checklist. The CAP checklist makes things easier because it gives you the grade grouping scheme of things within the report, so that all you have to do is you have to click on the, you have to tick on the grade group. So there were a few problems with this ISUP 2014 modification, because since it was a radical change from the original Gleason grading system, there was a bit of a problem comparing it with the scores which were obtained from the original Gleason grading system. Another important thing was that we talk about the concept of grade groups, etc. But in a case where you have multiple cores from different sites being given to you, if you have, say, a Gleason score 3 + 3 = 6 on multiple cores, that is, most of the cores fall into the grade group 1. If you have a single core with 3 + 4 = 7 going into the grade group 2, would you sign out this case as an overall case of grade group 2 or a grade group 1? Now, we shall talk about this in detail later as we go down the discussion. So in biopsies, there was no proper discussion on whether the group would be based on an overall global score of all the cores together or the worst score. And also, because there was no threshold of 5% as far as defining the higher grade pattern is concerned, this would, of course, lead to some amount of inter-observer variability. And also, there was a considerable overlap in the grade group schemes as far as the clinical outcome is concerned. And which obviously raises the question of whether the tumors with 5 + 3 = 8 score or 3 + 5 = 8 score are likely to behave in a manner similar to 4 + 4 = 8, because all these three would actually go into the grade group 4. So these are the various kinds of modifications which are overall incorporated in the 2005 and 2014 modifications of the Gleason grading system. You'll have to remember all of these modifications because they incorporate not only definitional changes but also operational changes. And we usually talk about the 2005 and 2014 modifications as a single concept of the 2005/2014 modifications of the Gleason grading system. Now, coming to the routine applicability of the Gleason grading system in prostatic biopsies. If you are working in an institute with an active urology department, you will usually see that most of the cases where you have to score a prostatic biopsy comes in the form of 12 containers. And this is easy to understand because all you have to think of is from the clinician's perspective. They have divided out the prostate into the right and left lobes. And each lobe has been again further subdivided into the medial and the lateral aspects. And of course, we know that there are three important anatomical levels for the prostate. That is the base, the apex, and the mid zone. And you have to basically sample each and every of these zones. So you can understand that there will be cores which are taken out from the left and the right. And each lobe will again have sampling of lateral aspect in the base, in the midline, and in the apex, and also in the medial aspect, the base, the midline. That is the middle and the apical portion. So at the end, you end up with 12 cores given out to you in the form of 12 individual containers. And that is the standard transrectal ultrasound guided 12-core systematic biopsies, which is the more or less the diagnostic standard nowadays. And for simplifying the things, and as advocated in many of the guidelines, you usually get a single core in each container, and that makes your job very easy because all you need to do is a specimen level / core level reporting, because each and every of your specimens has got only one course, and you are basically supposed to give out the total Gleason score and the grade group, etc., for each and every core, that is each and every zone or sample that has been given out to you. So this is the 12-core systematic biopsy, which is routinely practiced. The image on the left shows you what zones are actually sampled in the case of a 12-core ultrasound guided systematic biopsy. But then, as we see in this particular case, when we see from the top-down view, you see that there is a tumor which is sitting in a location which is not accessible by any of these core biopsies, which we are accustomed to in the 12 core systematic biopsy approach. So this particular cancer is sitting in a zone which is inaccessible for these cores. So in those cases, what you will get as an additional sample is a MRI guided biopsy, MRI guided targeted biopsy from that cancer. So you will have a container where maybe 3 or 4 of those cores are actually given out to you for a separate scoring apart from your 12 core systematic biopsy sampling. And just not that, in the initial illustration, I've showed you the case where the clinician gives you individual pots or individual containers and you make individual blocks out of it, making your job simple. But sometimes, depending upon institutes and upon the urologist's choice, you will have 2 of the cores given together in the same container. And how are you supposed to identify the cores in this case? Because there will be 2 per container. Oftentimes, in such cases, the urologist will mark out one of these cores, specifying the zone with India ink. So in that particular case, you can still approach your case just like a 12 core biopsy, because you know that a few of these containers will have only 1 course, and those containers which are having 2 cores will have one of the core marked out with India ink. So you will again have to give individual level Gleason score and grade grouping, that is core level biopsy for each and every of these specimens. And what are the various parameters that you will note out in the case of the needle biopsies? Keep one thing in mind, that as far as the TARP specimens and the needle biopsies are concerned, the range of data set that you will have to give to the clinician are more or less identical. You have to give a total of the Gleason score and also a mention of the grade groups per core. If there is a pattern 4 or a pattern 5 in your case, you will have to also quantify and give a percentage range of those particular patterns in your sample. You will have to talk about the presence of perineural invasion, lymphobascular invasion, and seminal vesicle invasion if it is present. Extraprostatic extension, again, if it is present, you will have to make a note of. If there is an intractal carcinoma of the prostate, you will also have to quantify that and give an approximate idea of how much of the core or your TARP sample is occupied by intractal carcinoma and coexistent pathologies, if any. Now, how will you report such prostatic biopsies? So in the United States, what is done is usually you will get a 12 core biopsy done and send in individual containers, and you will have to report each and every of these cores as an individual core level biopsy. But again, in some countries, as in Europe and in Canada, sometimes they might, add together all the scores together and get a single case level, get a single overall Gleason scoring. And in some cases, you might even have a type of a reporting where you talk about the case level kind of a reporting with the core with the highest grade and the highest score. So in the case of the USA, what the clinician will do is mostly they will look at all the individual Gleason scores for all the cores, and they will choose the one with the highest Gleason score as the one which will ultimately decide on what kind of treatment the patient will get. In any case, you are supposed to report the Gleason score for each site, the total number of cores involved, and the percentage involvement of each involved core. So this is the minimum data set that you will have to provide to the clinician in a case of a standard biopsy, which involves a combination of TRUST-guided 12-site systematic sampling, plus in some cases, an MRI-guided targeted biopsy along with that. So you see that there's a humongous number of data points that are generated by this particular kind of an approach, because not only do you have to report each and every of these categories, you will have to report each and every of this category at a core level or a specimen level and talk about each and every feature for each and every core. Of course, because of this huge number of data points which are generated, it makes things easier for artificial intelligence to basically summate all these things together into a single cohesive report, and which is why we are seeing more and more utilization of AI softwares as far as Gleason scoring is concerned. And maybe around 10-15 years down the line, we won't even have to go into the Gleason scoring system and sign out a report by going through the microscope and taking a lot of effort to talk about the scores and the grade groups, etc. It will be entirely done by artificial intelligence. But till then, you will have to know about the way in which you report such cases. So for example, this is a model which has been picked up from a textbook, where you see that each and every course of each and every site is specified out, and what is given out is a Gleason score along with the grade group. And amount, that is the quantification of the amount of the core length which is occupied by the tumor, and also the percentage of the core volume which is occupied by the tumor. And if there is a cribriform growth pattern, which is again prognostically significant, you also make a note of the presence of the cribriform pattern. So as I've already said, there are various kinds of reporting. If you are choosing to report the core with the highest Gleason score and the grade group, you will report it as a kind of a case level summary. But what we do in our routine practice is mostly we go by the specimen level reporting, where you give out a Gleason score, grade group, etc., for each and every specimen that you are getting. In many cases, if the specimen contains just one core, your specimen level reporting would actually match the core level reporting. But what happens if you have got different cores with different grades? As I've already said, if it is in America, you'll see that the clinician goes for the core with the highest Gleason score and accordingly prognosticates the patient and plans the treatment. But in the case of Europe, overall, that is a composite or a global Gleason score might be utilized. So for example, if you have got multiple cores in Europe, they will tend to basically unite, that is kind of summate the findings of each and every core together into a single overall Gleason score and then choose the treatment regime. So how you report out the cores as per the Gleason grading system will depend more or less on your local practice. Either you could be reporting at an individual specimen level or a core level, or you could give a composite or a global grade based upon how your urologist wants the report to be. Now, for example, let's pick up one such case. Say, for example, you have got 4 cores. You have got scores of 3 plus 3 equal to 6, 3 plus 4 equal to 7, and 4 plus 3 equal to 7. So you have got 3 cores. And you have also got a core with 4 plus 4 equal to 8. So how do you report such a case? If you are to give an overall score in this particular case, depending upon which one is the predominant pattern 3 or 4, you would basically give it an overall score of 4 plus 3 equal to 7 or 3 plus 4 equal to 7, depending upon the predominant pattern. However, this would probably not be a good way of reporting in some cases, because quite a few studies have shown that since there is a core with a 4 plus 4 equal to score 8 or a grade or a Gleason grade group 4, that particular core actually will correlate with what you see in the case of radical prostatectomy. That is, in such case, if you were to do a radical prostatectomy, you would probably get a final Gleason score of 4 plus 4 equal to 8. So this particular problem can be eliminated. This particular problem of overall scoring can be eliminated if you diligently give out a score for each and every biopsy site that is given to you. So as long as you are able to identify the site of the biopsy in the specimen or in the core, it's best to give out a grade for each and every of these specimens separately. That makes things easier for the clinician to kind of prognosticate the patient. At the end, you also have the option for giving out a composite score. Now, what is this concept of composite score and global scoring? Okay, so there is a slight difference between the two. So say, for example, in this particular case, we see that multiple zones have been sampled. We see that towards the left, for example, the cores have got only pattern 3. So both these cores have got only pattern 3, that is 3 plus 3 equal to 6 would be the score given out in this side. While towards the right, we see that out of 4 cores, all the 4 have got variable degrees of pattern 4. So in some cores, the pattern 4 is the predominant pattern, giving rise to a 4 plus 3 equal to 7 score, while in some, pattern 4 is the only pattern, giving rise to a 4 plus 4 equal to 8. So the highest grade among all these cores is basically this, like this one, where you get a score of 4 plus 4 equal to 8. Now, given the fact that most of these cores are having good amount of pattern 4, you have probably hit upon a dominant nodule, which is the largest tumor nodule that you can get in a particular case. So in such cases, it would probably be wise to summate the findings of all the 4 cores together and give a composite grade of 4 plus 3 equal to 7, because 4 is the predominant pattern as far as these 4 cores are concerned. On the other hand, the global grade in such a case would be, if site irrespective, you summate the findings of all the cores together and give a total score. So the global grade in this case would be basically 3 plus 4, because if you see as far as the distribution of the patterns is concerned, pattern 3 is still the commonest pattern. So the global grade would be 3 plus 4 equal to 7. The composite grade for the same case would be 4 plus 3 equal to 7. Obviously, the two are not the same. 3 plus 4 equal to 7 would basically count as a grade group 2, while 4 plus 3 equal to 7 becomes a grade group 3. And most importantly, the highest grade pattern is actually the grade group 4 over here, this single core with a score of 4 plus 4 equal to 8. Now, depending upon your understanding of the case and how the case has been presented to you by the urologist, you might choose to give a composite grade, which would be which would be kind of an undiluted grade for the dominant nodule. In such a cases, if you are to give a global grade, you would actually be diluting the entire issue, because you will be factoring in cores where there is not that much of serious disease, right? So it will depend upon the case scenario, where you will be choosing either the composite grade or the global grade. It has been seen that composite grade results usually correlate better with the final grade, which is seen in the case of radical prostatectomy specimens. Now, this is about cases where you get individual level specimens with single cores of multiple sites nicely labeled out to you, where you give out individual core level or specimen level scores. But what happens in the real life? So this is the ideal scenario, which I have talked about priorly. But in your routine practice, you will see yourself more often dealing with samples like these. So for example, you might be given 2 containers with just a mention of right and left, 5 or 6 cores jumbled together, with the result that quite a few of these cores are breaking off. The more number of cores you put in a pot, the more the chances of breaking. And of course, such beautiful concepts of individual core level reporting, specimen level reporting, etc., goes for a toss in this case, in this kind of cases, because you don't have an idea of which side these particular cores are taken from. So of course, in such cases, the way in which you finally give out the Gleason score will actually differ from a very well thought out 12 core approach. Like say, for example, in this particular case, where it was told by the clinician that there are 3 containers and each container has got 2 cores. As is expected in such cases, the more the number of cores that you put, the more is the chances of fragmentation. So while the central one has got 2 cores nicely made out, so in this particular case, you can do a core level reporting. You can mention that one core has got this Gleason score, grade group, etc., while the other core has got this kind of Gleason score. But in these cases where the cores are basically fragmented, as you can see that in this particular case, the technician has still done a good job of it. That is, the embedding has been in such a way that you can make out one core, and the other core, although it is fragmented, gives you an approximation of a single core. While in this case, of course, the core has got fragmented beyond repair, and you cannot really talk about 2 cores in this setup because of the degree of fragmentation. This is still a case which is salvageable. Okay, but in this particular case, which has been taken from a journal article, you can see how hopeless the scenario is, because say 4 or 5 cores have been put together in one container, and the net result when you get the slide is something like this. So maybe around 3 cores or 4 cores have got fragmented into 20 or 21 cores. So in such cases, it makes no sense to talk about individual core level reporting, and what you will have to go for is the overall Gleason score, that is talking about those particular cores, or rather the core fragments which have got fragmented, and saying that this many number of fragments out of these many total fragments have got the cancer. So from the technical point of view, although the single core site specific 12 core systematic biopsy is the way to go and makes jobs kind of simpler for us, in real life we shall be dealing with fragmented specimens without a mention of the site of biopsy, exact site. So in such cases, we will tend to usually go by the overall global score by making an average of the findings that you see in the individual cores. I'll give one example. Like say, for example, in the image at the bottom end of the screen, you see that there is a degree of fragmentation of these cores. So although there are 6 cores over here, you see that there is some amount of fragmentation. Now, if you are to obviously, if you have a predominant pattern of 3 and a secondary pattern of 4, the final score in this case will be 3 plus 4 equal to 7. Now, what happens if you diligently keep on giving a score to each and every fragment which comes along? You will be probably seeing a single core fragment which has got only pattern 4, and you will be giving a score of 4 plus 4 equal to 8. Now that would be laughable because we know that this particular small fragment of the core has come from a single larger core which has got basically a pattern of 3 and a secondary pattern of 4, that is core 7. So in such cases you will obviously ignore that small fragment and you will go for the overall global score. So the rule of the thumb is if you do not have a site designation and if you get multiple cores sometimes fragmented together and without any identification about the site, go for the overall global score. And what about the composite versus the worst score when you are hitting a certain dominant tumor nodule? There again, the opinions differ. Again, things will be depending upon how your biopsy sample turns out in this particular case. Like say, for example, in the example A, you see that the pattern 3, in 3 cores, pattern 3 is the predominant pattern to the point that in the third core, there is only a pattern 3. There is smaller, that is secondary pattern of pattern 4. But in the last core, you see that it's only pattern 4 without any pattern 3 whatsoever. So in such a case, because a single core has got only pattern 4, it probably means that you have got a separate tumor nodule, which is probably of a much higher grade compared to what you see in the rest of the cores. So in that case, it would be probably best to report the worst score because that will give an idea to the clinician about the prognostication. On the other hand, in the case in example number B, you see that there are 4 cores with varying degrees of presence of pattern 3 and pattern 4. So you see that there are 2 cores with 3 plus 4 equal to 7, 1 core with 3 plus 3 equal to 6, and 1 core in which you get only pattern 4, that is 4 plus 4 equal to 8. In such a case, because there is a kind of mixing up equally of pattern 3 and 4, you will tend to give the composite score in such cases, averaging out the total pattern. As per the CAP checklist, if you see, this is how the reporting is usually done. So for example, in a case of systematic biopsy, here they have segregated the case into a right versus left approach. You see that out of a total of 6 cores, 1 of the cores is involved in the right. So that core has been highlighted with red, and then it has been further segregated into the kind of patterns which are seen in that particular core. Like say, for example, in this core, in this single core which is involved, you have only a pattern 3. So the final Gleason score is 3 plus 3 equal to 6. And you are also supposed to give an idea of the linear length of the extent of the tumor. That is 4 mm in this case. On the other hand, in the left-hand side, you get a total of 6 cores, out of which 2 are involved. And out of these 2 involved cores, you see that again, a segregation has been given between how much of the code is pattern 3 and how much of the code is pattern 4. So in the first case, 3 plus 4, because the dominant pattern is pattern 3 and the secondary pattern is pattern 4, 3 plus 4 equal to 7 is the score which has been given. The total length of the tumor has been given, and the percentage of the Gleason pattern 4 is also mentioned because that is a prognostic significance. While in the second core, since there is only one pattern of 3 plus 3 equal to 6, you don't have to basically talk about any degree of presence of the Gleason pattern 4. Now, this was the systematic 12-core biopsy that we have talked about. But what about the targeted biopsy of those nodules which are beyond the reach of systematic biopsy? In these cases, you will usually get a single container or maybe 2 containers if there are 2 sites which are suspicious. And you will get 3 to 4 cores maybe in that single container. In that case, since the cores all come from the same nodule, you did not give out an individual level scoring for each and every of these cores. You can very well summate these things together into an overall Gleason score from the targeted biopsy site. And that is what the CAP checklist tells you. So it's best to report such cases following the CAP checklist. So if you see, CAP tells that for each specimen, for each positive specimen, you are supposed to give out individual level Gleason scores and so forth. So you have got the grade group 1, you have got grade group 2, score of 3 plus 4 equal to 7, obviously. And as I've already said, any degree of presence for the pattern 4 will need you to quantify the percentage of the pattern 4 in that sample. And obviously, you won't get a single value out of it, so you will have to give a range. Now, once we move to the grade group 3, we see that the predominant pattern is Gleason score, that is 4. So again, you are supposed to mention about the percentage of the tumor tissue which is occupied by the pattern 4. Moving on to the higher grade patterns, that is those which belong to the grade group 4 and the grade group 5. Since you have a substantial amount of presence of the pattern 5 in these cases, you will have, in such cases, you will also have to mention about the percentage of the pattern 5 along with the percentage of the pattern 4. If you have an interrectal carcinoma in this particular case, you are supposed to make a note of it. Cribriform glands, again, as I've said, in the pattern 4, cribriform glands is of prognostic significance. So if you get a Gleason score of 7 or 8, where you obviously have got a pattern 4, you are supposed to mention about the presence of cribriform glands if it is present. And obviously, at the end, you will have to quantify the tumor. Now, quantification of the tumor, if you have only a single core, and if a large amount of the tumor is present in that core, sometimes we will not go and diligently measure out the length of each and every of the zones. We will probably give an eyeball estimate, like say, for example, in this particular case, say around 85% of the tumor, 85 to 90% of the tumor of the area is occupied by this tumor, while in the upper one, around say 60 to 65% of the core would be is occupied by the tumor. In this particular case, also say around 60% of this core is occupied, of this core volume is occupied by this tumor, which looks like it's of 4 plus 4 equal to 8. But what about cores like this, where you have a very small proportion of the core which is occupied by the tumor? In this case, 3 plus 3 equal to 6. So in these cases, you will basically have to use your ocular micrometer and give a diligent measurement of the length of the core which is occupied by this particular tumor. And then there is this issue where you have a single core and the two ends of the core, that is two separate zones, are occupied by cancer and the intervening zone appears to be free. Okay, and so how do you report such cases? Do you consider this length of the core between the two areas of cancer as also involved by the core? Or do you say that just there are two individual foci of cancer and the rest of the tissue is free? So the best way to report such cases would be to measure out by ocular micrometer the length of the cancerous areas, and then to talk about it in the context of the total length of the core. So for example, in this particular case, if it is 1 millimeter area which is occupied by each of these cancers, we say that there are foci of discontinuous involvement by cancers which occupy 1 plus 1 equal to 2 mm, that is 10% linear extent, out of a total core length of 20 mm, that is the 100% linear extent. And sometimes, as I've already said, some biopsy samples, you will get a container with 3 cores or 2 cores together, in which case you are also supposed to give the composite extent. In that case, again, you measure out with ocular micrometer the length of the individual cores which is occupied by the cancer, and then summate the 3. So for example, here you have got 3 cores, out of which 1 is free and 2 are involved. So the length of the cancer in the entire number of the cores is 5 plus 2 mm out of a total length of 13 mm plus 16 mm plus 6 mm. So you have around 20% volume involvement in this particular sample. Now that was about the core biopsy specimens. Now coming to the radical prostatectomy specimens, the most important thing that we have to keep in mind is that the scoring mostly pertains to what is the single largest nodule that you see in this particular case, that is the dominant nodule. As you know, in the case of prostate cancer, often the involvement is multifocal and you will get smaller nodules in the adjacent prostatic stroma which are separate from the dominant nodules. But in most cases, it will be the dominant nodule which will be the area that will finally determine the actual grade and the stage of the patient. So it's very important that you almost entirely sample the dominant nodule and give out the final Gleason score and the grade group based upon the dominant nodule. As in this particular case, the blue is basically the one which is the dominant nodule, and you are supposed to give out a individual Gleason score and the grade grouping of this particular dominant nodule. So the dominant nodule is usually the largest nodule with the highest grade and stage, and it has to be given its own Gleason score and its own grade grouping. Now let's directly jump into a few examples. So here you have a dominant nodule. You see that the predominant pattern is occupied by pattern 4, say 60% of the area. The second common pattern, that is the secondary pattern, in this case is occupied by pattern 3 areas of 30%. And you have got a very less common, but a much higher grade pattern of pattern 5, occupying 10% of the area. So which particular Gleason score or the grade group would this particular case figure in? So for that, you will have to know a few of these guidelines. So supposing you have a radical prostatectomy specimen with 3 patterns, 3, 4, and 5, obviously, because these are the only 3 allowable patterns. If there is a portion of the highest grade pattern which occupies less than 5% of the volume, you will classify that highest grade but minor volume pattern as a tertiary pattern, and you will score the dominant nodule as a combination of the primary pattern and the secondary pattern, and you will have to make a note of the minor high grade pattern being present as a tertiary pattern. So for example, if the primary pattern is pattern 3, if the secondary pattern is pattern 4, and if the highest grade pattern occupies less than 5% of the area, you will give it a score of 3 plus 4 equal to 7. That is the grade group 2, with a tertiary pattern 5, that is a grade group 2 with a minor high grade pattern. On the other hand, if you have a primary pattern of 3, a secondary pattern of 4, and you have more than 5% of this nodule occupied by the pattern 5, you will now have to go by the most plus the highest rule and give it a final score of 3 plus 5 equal to 8. And in that case, you see that the grade group jumps directly from grade group 2 to grade group 4. So this is the rule of reporting a radical prostatectomy case with 3 types of patterns. So 5% is your diagnostic threshold as far as calling the highest grade pattern as a tertiary pattern or a pattern which is to be summated into the final grade is concerned. So going by that particular logic, let's pick up the previous example. You have a predominant pattern, that is predominant pattern of 4 of 60%, second common pattern of pattern 3, and a least common but high grade pattern of pattern 5 occupying 10% of the area. So in that case, because the highest grade pattern has crossed your 5% threshold, your final score will be a predominant pattern of pattern 4 plus the highest grade pattern of pattern 5, that is 4 plus 5 equal to 9, going to the grade group 5. But now let's take up this scenario where you have only 2 patterns. Okay, so you have a predominant pattern, which is pattern 4, but the low volume secondary pattern, meaning the pattern with less than 5% representation in the tumor nodule, has got a pattern of 5. Okay, so here you have 4% of the tumor area occupied by this pattern 5, say. So how would you score this particular case? Now, this is where things become a bit controversial. So if you were to go by this original journal article, of which one of the authors was Dr. Epstein, he has categorically mentioned that if you have only 2 patterns, and if you have a low volume secondary pattern of less than 5%, if that secondary pattern is of a higher grade, then there's nothing doing. You will have to factor in that thing and add it to your score. So even if there are only 2 patterns, and if the higher grade pattern, say pattern 4, occupies less than 5% of the area, you will have to score it as 3 plus 4 equal to 7 and put it in the grade group 2. Now, this is a major departure from what ISUP basically says. And this particular question was put up as a kind of a consensus question in the ISUP 2019 meeting. And see, the issue is the same. So for radical prostatectomy, any amount of Gleason pattern less than 5% should be included in the score as a secondary pattern. Should we do it? No, 67% disagreed with that approach. Similarly, for any radical prostatectomy specimen, if you have a pattern 5, should we include it as the secondary pattern if you have even less than 5% of the area occupied by the tumor? No, again, majority of the individuals disagreed. So this is not a viewpoint which is shared by a large number of genitourinary pathologists. So where do we stand on this particular issue of only 2 patterns and the higher grade pattern occupying less than 5% of the tumor area? Now it depends upon which set of guidelines you follow. As you see, as I've already said, the field of urological pathology has now got split between 2 sets of guidelines, one which is given out by ISUP and the other by the Genitourinary Pathology Society, or GUPS. Now, depending upon which particular set of protocols you follow, you will find that you are reporting such cases in 2 different ways. So for example, if you are going by the ISUP guidelines, and if you have a case where it is predominantly pattern 3 and with less than 5% of pattern 4, you will still report it as 3 plus 3 equal to 6 and make a note of the pattern 4 as a minor pattern 4. You will not figure the pattern 4 in your final Gleason scoring. But on the other hand, if you were to follow the Genitourinary Pathology Society guidelines, you will see that the same case where you have less than 5% pattern 4 and predominantly pattern 3, you will be reporting it as Gleason score 3 plus 4 equal to 7, mentioning the presence of less than 5% of pattern 4. Now, this is really important because if you are following the ISUP guidelines, in the same case, you are giving out a score of 6 and putting the patient in the Gleason grade group 1, while if you follow the Genitourinary Pathology Society, you are basically putting the patient in the grade group 2. Now, this is a set of conflicting recommendations of which we cannot really do anything much. As far as me and you are concerned, if you get a radical prostatectomy, we shall probably play it safe and go by the ISUP guidelines and still talk about minor or tertiary patterns, while those following the Genitourinary Pathology Society guidelines will go about it in a different way. So now let's talk about the same issue that I talked about, predominant pattern, majority of the tumor nodule being occupied by pattern 4 with less than 5% of area occupied by pattern 5, that is the higher grade pattern. So going by the ISUP guidelines, of course, you will only make a note of the presence of the minor pattern 5, but you will overall score the case as 4 plus 4 equal to 8. Okay, so your case is of a grade group 4. However, if you follow the guidelines which are given by the Genitourinary Pathology Society, even that less than 5% of pattern 5 will have to be factored into your final score, and you will end up with a final score of 4 plus 5 equal to 9, making a note of the presence of less than 5% pattern 5, that is putting the patient in the grade group 5. What about the CAP guidelines? Now the CAP actually plays it safe, because as far as the CAP recommendations goes, you can actually choose either the ISUP way of reporting or the Genitourinary Pathology Society approach, but you will have to make a note of the presence of the percentage of the higher grade pattern that you are reporting out. The same applies in the case of the WHO approach currently. So in the case of radical prostatectomy specimens, if you have less than 5% of the tumor, you, depending upon whether you are following the 2019 ISUP guidelines or the 2019 Genitourinary Pathology Society guidelines, you will give out different scores, basically. So now one thing you have to keep in mind is that these 2019 grading changes have not yet been fully validated, and there are some specific differences between the recommendations which are put out by the two bodies. So you will need to be careful about the differences between these two set of guidelines. We shall be talking about them briefly in the last slide. And if you follow the CAP checklist for radical prostatectomy specimens, again, you see that the CAP checklist is kind of biased towards the ISUP style of reporting, because again, you have grade groups which are mentioned, and you have a mention of the tertiary pattern, meaning that if you have a pattern, a high grade pattern of less than 5%, you are free to report it as a tertiary pattern without putting it into the final score. Okay, so these are the various grade groups again, which are listed out in the radical prostatectomy. Finally, talking in brief about the major differences between the Genitourinary Pathology Society guidelines and the ISUP guidelines of 2019. One we have already, one has been already discussed. If you have a radical prostatectomy specimen, only one predominant pattern with a very minor high grade pattern, as far as the ISUP guidelines, you will only talk about the higher grade pattern score and mention the presence of the minor pattern score without putting it into the scoring formula. While as far as the GUPS guideline is concerned, you will have to add that particular pattern to your final score and record the percentage of the pattern. And as far as the presence of intrarectal carcinoma of the prostate goes, if it is associated with invasive cancer, as per ISUP, you will have to grade the intrarectal carcinoma also. While in the case of the GUPS guidelines, you do not grade intrarectal carcinoma of the prostate, irrespective of whether it is present or unaccompanied by a cancer. So as we have already discussed, the 2019 grading changes which have been proposed by ISUP and GUPS are not validated fully. There are obviously differences between the approaches of the two set of guidelines in the case of the radical prostatectomy specimens with only 2 patterns. And of course, there is also a certain difference in their approaches as far as reporting the intrarectal carcinoma of the prostate goes. So at the end, you can talk about the ISUP 2019 modifications to prostate grading, summarizing it into this 9 set of guidelines. Most of it is actually an extrapolation of what was arrived at in the ISUP 2005 and 2014 consensus classifications. And last but not the least, you have to remember that this set of guidelines is just a standing set of instructions, and you will never actually be familiar with the thing unless you are reporting these things on a regular basis. So the more you practice with this set of guidelines at hand, the more you will get better at reporting out Gleason scores and grades. Thank you very much.